And I've been asked to talk about the whole spectrum in 15 slides, so I found that quite a challenge and thought, well, why not, Look, genetic risk and ovarian cancer has been a big topic lately with Angelina Jolie. If diagnosed at the localised stage, and that's only about 15%, unfortunately, the 5-year survival of ovarian cancer is about 93%, but most of them are diagnosed when the disease has already spread, because we don't have a good screening test for ovarian cancer. So there's an area for research all the way. In terms of genetic risk, however, 9 out of 10 ovarian cancers are sporadic. They don't have the genetic risk. We don't know all the factors involved, but most of them are not part of family history. So 1 out of 10 have genetic changes. There's the ones related to the BRCA1 and 2 genes. There's the hereditary non-polyposis coli, which is an hereditary condition where you primarily get bowel cancer, but you can also get ovarian cancer, and then there's some various ovarian-specific things. And the difference between a hereditary cancer, or one of the main ones, is they tend to occur earlier. So younger women tend to get the hereditary cancers. Now, it's, I don't know, too much choice. Angelina Jolie has highlighted this recently because she's revealed that she had an inherited mutation, and she was faced with the problem of, what do I do now? Do I have bilateral prophylactic mastectomies and an oophorectomy, because the BRCA1 and 2 genes talk about risk for both breast cancer and ovarian cancer. And the difficulty is, when you've got that, you're often less than 50 when you have your diagnosis. There's an increased chance in the inherited ones that you'll actually get the disease in either both breasts or both ovaries, because it's the same factors relating to both breasts. And because it's what we call autosomal dominant, the inheritance can either be through your father or your mother. If one of them has got the changed gene, then you'll inherit the predisposition. So the Angelina Jolie story is a two-edged sword in a way. I mean, it was nice to have some spotlight put on this, but on the other hand, it's a very complex issue for a woman to decide what they're going to do, whether there's going to be screened more obsessionally to hope to pick up any disease earlier, or whether they're going to have either the breasts or the breasts and the ovaries removed. And having the breasts removed is a far lesser issue than having the ovaries removed, and the difficulty we had is we didn't want women to say, well, if Angelina Jolie is going to do it, I'm going to do it. And the other thing was, there's no sense in which that type of decision has to be made quickly. You've got time to talk about it, to talk to clinicians about it, but particularly perhaps to talk to other women that have faced that decision in support groups and so on, and make a decision that's right for you, because we all have different balances in our lives and so on. And Angelina Jolie hasn't had her ovaries removed, as far as we're aware, because she still is interested in further children. I mean, she's got 6 already, but obviously that's not enough. Now, the other interesting thing this morning about talking about BRCA1 and 2 mutations, I always try and keep my talks up to date, but the reality is that last night in America there was a pivotal decision made by the Supreme Court when they decided that the myriad patents on the BRCA1 and 2 genes were invalid. And so that's going to cause all sorts of discussions. It doesn't have a direct effect on Australia, but of course, as you know, there's an ongoing appeal in the court case of Cancer Voices versus Genetic Technologies, really, about whether you can have a patent over a gene that's been removed from the body just because it's been removed, whether that makes it patentable. The American court has made it very clear. They've said you can't patent a gene in the body, and taking it out you can't patent it either, because that's not enough. You've got to actually do something clever to get a patent. Now, there's other things I can go into in question time because they will allow patents on complementary DNA, but that's another story. So, if you've got a BRCA1 mutation, the figures are perhaps better known for breast cancer, that you've got an 85% lifetime risk of getting breast cancer. In ovarian cancer, it's usually considered 20 to 40% lifetime risk. And so that's the problem. You mightn't get your cancers till you're in your 70s, and yet you might be making this decision in your 40s and 50s. With BRCA2, it's a lot less. It's 10 to 11%. And there are other lifestyle factors that will mitigate risk as well. Oral contraceptives and pregnancy in general decrease the risk of a BRCA carrier developing ovarian cancer. There's a question about what that might do to their chance of having breast cancer, and that's part of the complexity of that. Whereas tubal ligation, having tamoxifen for breast cancer or breastfeeding have no effect. There was a suggestion that breastfeeding may decrease BRCA1, but these are population studies where you can't actually show cause. So oral contraceptives in ovarian cancer may decrease the risk, but then the difficulty is, does that actually increase your risk of getting breast cancer? So these are very complex decisions that shouldn't be rushed. I guess the good news is the BRCA1 carriers actually survive better than the sporadic ovarian cancers because they tend to respond better to the main drug we use in combination in this disease, and that's cisplatin. Most BRCA mutations are unique to families, but some occur in ethnic groups, particularly the Ashkenazi Jewish population, and essentially it's because there's a bit of inbreeding in that group, and so it sort of amplifies, if you like, the chances of getting the mutation. And what's more, they have the same mutations as each other, whereas there might be a different pattern in the BRCA gene between one family and another in the wider world. And as I said, children with a parent with a BRCA1 mutation have a 50% chance of inheriting it. Now, what about the question of screening? For a start, not everyone is going to be screened for your BRCA1 and 2. Usually genetic counsellors will screen people where an index case, your relative, your mother, your sister and so on, has a known BRCA mutation, so you know where to look. So it's something that's kept for people that are likely to have the mutation. And of course it's an important result, because if you don't have the same BRCA mutation as your relative, then you've only got the same risk as the rest of the population of getting these diseases. If you do, you have in ovarian cancer up to a 40% lifetime risk of getting the ovarian cancer. Can you screen? Well, it's been suggested that you should perhaps have 6 monthly transvaginal ultrasound, which is just an ultrasound that is good at looking at the ovaries, plus this blood test, CA125. And this should start sort of in the mid-30s, or at least 5 to 10 years before the age of your relative. Now, that's been one suggestion, but I've got to talk about that because that's not an easy thing to do, and it's not necessarily an accurate thing to do, which is why some research in ovarian cancer needs to look for a better screening test. And then what's your option if you have it? Well, in terms of treatment, you could have the ovaries removed, but before you do that, you've got to know about the impact on libido. When the Angelina Jolie story broke, people were sort of saying, look, you have reduced libido when you lose your ovaries. And one woman that was interviewed in a Western Australia paper said, I was told all that. What I didn't realise is that I actually have no libido at all, and it's made a significant impact on my life. And so it's a relative thing, and it's something that every person has to weigh up. And the other thing is, with prophylactic mastectomy and oophorectomy, there's not 100% guarantee that it'll be effective, that you get all the tissue, and people have to realise that as well. I mean, a subcutaneous mastectomy, for example, could leave a little bit of breast tissue behind. Bilateral oophorectomy, if all the ovarian tissue isn't where the major bulk of the ovary is, it could leave a little bit of tissue behind that could be the subject of further cancer. So it's not 100%. And this is why each person has got to go into that decision very carefully and make it according to their lifestyle, whether they want more children and so on. What's the problem with the screening test? Well, only 85 of 100 women with ovarian cancer will have a raised CA125, so it's not a very accurate test. It's quite good for following ovarian cancer. If it's been elevated when you're diagnosed, then you can follow the course of the disease with therapy and relapse, but as a screening test, not accurate enough. There's this sort of idea that a screening test of any type is better than none. It isn't. An inaccurate screening test can be quite difficult. It can damage you if you act on it and it's not accurate. Only 50 out of 100 women with early stage ovarian cancer have a raised CA125, and you're trying to pick it up. The idea of a screening test is you pick it up early enough to cure the disease, because if a screening test doesn't impact on mortality, then really it's not going to be very useful. And the other thing is, even with a raised CA125, you might have other conditions. Women with say, fluid in their abdomen for other reasons will have often a raised CA125. Is the ultrasound more accurate? Well, it is, but a little cyst may not be able to be identified as cancerous on an ultrasound. So you might see something, but you still don't know whether it's cancer. So we need a better screening test. That's the message with ovarian cancer. What about the treatment? Well, most of the in my 15 slides I can't go into detail, but what I wanted to show you was something. The main treatment is surgery, and in most cases followed by cisplatin, unless you've got very early stage disease where the surgery may be enough. And sometimes the chemotherapy is given before the surgery, depending on the extent or the stage of the disease. For relapse diseases, ovarian cancer, after you've had your platinum, there are other drugs, the taxanes, topotecan, oxaliplatin. A number of drugs have been developed that can be put in combinations to try and salvage the situation. Now, what I want to just present in the next two slides, these are my shock and awe slides. They're not meant to be taken seriously. But last week I happened to be at the American Society of Clinical Oncology meeting in Chicago. And that meeting has 32,000 people. It's the biggest cancer meeting in the world. And all the new stuff is presented. Now, what I wanted to convey in the next two slides is there's plenty of work being done in ovarian cancer that could lead to something more encouraging than what we have at the moment. So, for example, one of the studies was looking at the question I just alluded to. What about if you give your chemotherapy first? Does that make the surgery easier or more effective? And so there's a whole study looking at that. And as with other tumours, the major new treatments are what we call targeted therapies or personalised medicine. These are the ones that are homing in on the defective genes and their products, particularly if those defective genes are the ones that are driving along the growth of the cancer. And it's either immunotherapy or small molecules that will do something about the genes that are actually causing the problem in the first place. And there's a whole raft of studies in early disease and in relapse disease to try and look at these new targeted therapies to try and improve the outcome. And in a talk this morning you heard about bevacizumab or Avastin. It actually stops the new vessels from forming so the cancer can't nourish itself. And in this data presented last week, we've known from two big trials that if you add bevacizumab to chemotherapy, it tends to add benefit because you're killing the tumour with the chemotherapy and you're denying it a blood supply with the bevacizumab. And the trials show there is an advantage to putting those together. The study that was presented last week shows that you can even do that if you give the chemotherapy before the surgery, and it works better as well. So that's worth knowing in terms of planning the therapy.
Excuse me, Ian, before you go on, is that previous drug, is that like thalidomide and how they've been using that with other drugs for prostate cancer?
Yeah, look, when you have a new drug like this, it's often tested by adding to standard therapy because you can't give anyone less than standard therapy. Now, thalidomide has a different mechanism of action, but there are a whole lot of drugs that actually work on the vasculature now as well. So you're trying to hit the tumour from two different points of view, and that's the benefit of that. Now, the problem with adding in drugs to conventional drugs is, do you add into the toxicity and actually ruin someone's quality of life? So there was a trial called the Aurelia trial that was actually looking at the health-related quality of life of doing this addition, and they actually found that in recurrent ovarian cancer that had resisted first-line therapy, that regimens that had bevacizumab were associated with an improved quality of life. So you've got to put quality of life into these studies. It's not just good enough to have a few weeks or a couple of months more survival if you're going to actually pay for it by having a worse quality of life all the way along. And the other interesting thing with bevacizumab, since it's the targeted therapy that's sort of being most studied in ovarian cancer, is would it work if you injected it into the peritoneal fluid rather than give it intravenously? And it seems to be effective and safe by that mechanism. So that gives us another way of giving it, because there are some studies that show that in certain patients, putting the chemo, for example, into the abdomen is better than giving it intravenously. So you see there's a whole lot of fronts on which you've got to attack these tumours. Now, this is my shock and awe slide because there's a whole lot of names here that mean nothing to anyone really. They give drugs these days unpronounceable names, and Volasertib is actually just a small molecule that inhibits a protein that helps the cell to grow, and they did a study that found that the side effects are different from chemotherapy, and yet it's got some anti-tumour activity, so that can now be moved up into combination. Ganitinib is a monoclonal antibody, again, that showed some activity in patients that weren't responding to conventional chemotherapy, so that gives us a second line. And of course, the other thing that's being done in ovarian cancer, as it's being done in melanoma and other things, is to try and personalise the treatment by making a vaccine from the patient's own cancer cells that will be able to be injected back into the patient and prime up the body's own immune system to attack that cancer. So that's the sort of clever stuff that's going on. A couple more drugs, this tubulin polymerization inhibitor and a vascular disrupting agent. So this drug does both. It kills tumours and stops the vasculature. That was being investigated. And they're just looking at that early study where you find the dose and then go to find whether it's effective. And then eventually it'll be put in combination with chemotherapy. There are other drugs that are being looked at in pre-treated patients, and this drug trabectedin, actually 9 out of 16 patients who had it after the disease had stopped responding to platinum found that it actually shrunk their disease by at least 50%. So there's a lot of hopeful drugs out there. And then there was the question about, when you've given your chemotherapy, can you actually use a drug to maintain that response? And this is a particular type of drug that paralyses a pathway that BRCA1 patients, tumours like using to stay alive, and they found that in fact if you continued this drug after chemotherapy, you did actually get a better survival. So there may be a role for a sort of a maintenance therapy with one of these targeted therapies after the chemotherapy. My last slide, because I have to include survivorship, because that's really important. And I should have mentioned, I was going to mention, one of the drugs I was talking about earlier actually comes from a sea squirt. So people are looking everywhere for new drugs, and why would a sea squirt have a toxic chemical? Well, you've got to, poison the sea squirt next door if you want to survive, and so that's why trees and animals have these toxic things in their skin. And there's been cytotoxics made of tree bark. There's been cytotoxics suggested from the secretion on frogs, and this one was from a sea squirt. So there's a great discovery program going on. Survivorship. Look, it's been recognised that after you've finished your treatment is not the end of the road, that people faced with the whole experience and faced with their own mortality sometimes don't fit into their old lifestyle, and everyone thinks, oh, you've survived, you should be happy as Larry and go and buy a lottery ticket or something. They're not. And yet they don't feel they can sort of express that because it might seem ungrateful that you've survived cancer and you still feel miserable. But there are good reasons for that. There's a study that came out last week that looked at sort of depression and anxiety in patients that had survived cancer, and they actually found that the depression is more of a feature in the first 2 or 3 years and it's not so much of a feature 10 years later, but the anxiety still is. So we're talking about years after, and if we know about it, we can do something about it. We can support patients. So with ovarian cancer, you'll be followed by your CA125 if it was elevated at diagnosis, but every time you have a test, you'll get anxious about whether it's gone up again. Yeah.
Can I just ask you a question about the CA125? You mentioned earlier in one of the slides that for a number of women, it's not elevated.
Yep.
And I'm one of those.
Yep.
It wasn't elevated to start with. It didn't show up on ultrasound. How do I go now in terms of following CA125 going forward? Is there any medical help to me at all in following that?
Well, if it's not been elevated with your original cancer, unless something changes and some new clones of cells come up that produce CA125, it's not going to be very useful for you to follow for relapse with CA125. And that's why we need a better test. But every time you have a test, you get anxious. There are the things like premature menopause and loss of libido from having ovaries removed. There are some problems if you've had surgery. People often get swelling in the groins and you need to be managed with rehab with lymphedema, and that can be managed. And you've got to know that so you can go to physical therapy and have that done. And anxiety and depression can be managed as well. It can be just a matter of support. It can be a matter of support for sort of discovering what your new lifestyle is, which may not be like your old lifestyle, but may be perfectly satisfying if you can adjust to it. Now, these things are now well known, and if you can anticipate that this is going to happen, your oncologists, your primary care clinicians and other support groups of people that have been through this can actually help you through it. And we need to advertise this issue of survivorship, and there was a lot of research presented on that as well, I'm pleased to say. So that's all I want to say for the moment. I'm happy to take questions. I actually met with a pharmaceutical company yesterday. We don't have any relations with pharmaceutical companies, but we sometimes like to talk to them about these issues. And the reality is the price is set on what the American market will pay. And the American market will in general pay a lot more than the Australian market. So when it comes, and you can't have differential funding, otherwise everyone would just buy the drug in India or somewhere, and that would shatter the whole pricing structure. So the real dilemma is when it comes to Australia, it's got a price on it that's the American price, if you like, and you've got a government, the PBS, the PBAC and so on, that are trying to make a decision about whether the benefits of it are worth that cost. So the answer is it's a bilateral thing. It's how much they're trying to charge for it compared to how much benefit it has. And benefit is not only survival, it's also quality of life, as you've said. Now, I don't want to be unpopular here, but Australia has one of the highest cancer survival rates in the world. So overall, I have to say our system of picking the best drugs must have worked. But that doesn't mean it can't be improved, and it doesn't mean that some drugs wait for far longer than they needed to wait before they're approved. But they're the complex issues. The insight I got yesterday talking to this particular drug company is if they don't believe that they can make an appropriate price in the United States, sometimes they don't develop the drug at all. And that's a rather frightening concept, that you might have a whole lot of drugs in the cupboard that theoretically could work that you're never going to develop because you can't even make the price in the United States. So that's the complexity of the problem. I wanted to show those to show that the research was being done. They are not even available outside clinical trial. They're the early stage trials. And I just wanted to show a breadth of them to really say that, as you know, the longer you survive, the more likely it is that one of those will come through the system and be available. But I think if you've had a lot of relapses, then the greatest issue is seeing if you can find a trial that you fit into. And there are a lot of trials now in relapse disease, because sometimes that's the best way of studying a new drug.